All right, I'm going to try to pick up where we left off with upper and lower extremity injuries. So we have specific injuries to the upper and lower extremities. Tendinitis is the inflammation of a tendon caused by overuse. Hopefully you'll stop and pause the video here and go ahead and fill in the blank for these definitions, and then let me try to explain them to you a little bit better. That's how you'll get the most bang for your buck, so to speak, out of doing these recorded lectures, because they're a little more difficult because we can't interact per se. So, you know, if you can pause and look these up, some definitions, and then come back and hear what I have to say about it, you'll understand and learn it a lot better. But be sure that you do understand these different injuries, I guess, to the upper and lower extremities. So the first one we have is epicondylitis, which is called tennis elbow, also known as tennis elbow. This is an injury that occurs when the tendons of the medial or lateral, radial, and ulnar epicondyles sustain damage from excessive pronation and supination of the forearm. And that's because tennis players are constantly, you know, doing this over. So tennis elbow is over here when your elbow is hurting on the outer aspect of your elbow. The patient has pain in their forearm with a weak grasp. So actually what I had was not considered epicondylitis. What did they, I don't even know if they gave it a name. I'm trying to think if they gave it a name. Oh yeah, I'm going to talk about it on the next slide, looking at the other page. Okay, let me keep going. So ganglion cyst. Ganglion cyst, these are cystic mass that develops near a tendon, formed through defects in the tendon sheath or the joint capsule. The patient will have pain at the affected area, and most of the ones I've seen are on the wrist. They'll have ganglion cysts up here on the wrist. And so I don't know if you can see, you can't really tell great on the video, but this is my bone, but ganglion cysts, they'll pop up like that. The person bends their wrist down, you can see these big cysts pop up. So the old home remedy for ganglion cysts used to be that they would put a heavy book on there or a Bible and smack it on the cyst, and it would pop the cyst. And that's what they were doing. But there is a video posted on Blackboard. Please be sure that you watch the video. It actually shows draining of a ganglion cyst. All right, treatment for both include ice, heat, NSAIDs, steroids, analgesics, and rest. And sometimes surgery is required. All right, then we've got cubital tunnel syndrome. So cubital tunnel syndrome is similar to epicondylitis, to tennis elbow, except that with the epicondylitis, the pain is on the outside of the elbow, like I was telling you. In cubital tunnel syndrome, the pain is on the inside of the elbow. So that would be here where I've got my incision right here. That's where the pain is, right through that little corridor right here on the inside of your elbow. And this is actually sometimes called golfer's elbow. Okay, so it's caused by ulnar nerve compression. And you can have surgery for it. They can do surgery, obviously, which is what I did. And what they did was an ulnar nerve transposition. So what they did was they took the ulnar nerve that normally runs, you have these two bones right here in your elbow. Okay, it normally runs right in this little groove under your elbow. And what they did in my surgery was they cut that open, they get that nerve, and that ulnar nerve, and what they do is they pop it up here. So my ulnar nerve now sits up on top, and they kind of make a little groove in there for it to sit into. So it now sits up here on top and runs down into my pinky and everything, rather than down in this little groove. All right, so here's your pictures. This was, I guess, 2 weeks post surgery. So this was the day I got my stitches out. So the purple line there is just the marking that they have to mark your skin, you know, before they mark the incision, before they make the incision. So the purple is just where they have marked it. And, but you can see all this bruising, had severe bruising from where they had wrapped it. And still with the bruising, this is a couple of days later. But you can see where all the stitches were there, where they took them out. All right. Carpal tunnel. We hear lots of people with carpal tunnel. If we were in class, I would ask you all, because I'm sure somebody knows somebody that, or maybe somebody in class even has carpal tunnel syndrome. The carpal tunnel results from repetitive wrist motion that traumatizes the tendon sheath or ligaments in the carpal tunnel, produces swelling that compresses the median nerve against the carpal ligament. All right, so clients often complain of pain to one or both hands radiating up the forearm or the shoulder. The pain is often worse at night and early in the morning, and sensation may be lost or reduced in digits 1 through 4. So they actually have this numbness and tingling pain. Let me get these papers out of here. All right. In my family, I have a lot of people who work at Toyota. So working on the assembly line and that repetitive motion, constant repetitive motion. Let's see, my father-in-law has had both. He's actually had carpal tunnel done on both wrists, and he has had the cubital tunnel syndrome done on both elbows. So the ulnar nerve transposition as well as the carpal tunnel surgeries. And we have some other family members that same thing have had the carpal tunnel. That's the most common thing that people are out with, it seems like, on an assembly line, repetitive work like that. But also people who are on the computer all the time have a lot of carpal tunnel issues. All right, treatment includes splinting to rest the hands and the wrists, use of NSAIDs, periodic injections of corticosteroid preparation, and or surgery to release the pressure of the ligament on the median nerve. Now, they do diagnostic testing to determine if you have carpal tunnel, which actually, I didn't actually do one of these two tests. I did another type of test also, oh, it's not coming to me right now. Well, maybe it'll come to me anyway. I did another type of diagnostic testing as well for the cubital tunnel syndrome. But there's two diagnostic tests that you need to be sure that you understand. There are YouTube videos posted as well on Blackboard regarding these. So be sure that you have read about them and you have watched the videos and that you comprehend and understand how they work. One of them is Tinel's sign and the other is Phelan's sign. So in Tinel's sign, they detects irritated nerves. If the patient has carpal tunnel, the patient has numbness and tingling when you lightly tap over the nerve. And actually they did do that. They tested that on my ulnar nerve as well, though. They just had to tap and it zing right down into my pinky. That numbness and tingling. In Phelan's sign, the patient put their hand together for 30 to 60 seconds. The examiner applies force inwards, and the patients with carpal tunnel will experience numbness or tingling. Okay. Another thing they did for me with the cubital tunnel syndrome was if you put your arms up like this and hold your arms up, and after, they ask you, tell me when you start feeling, when your fingers, pinky and the next ring finger start going numb. And that's one of the other tests that they do. I don't know what the name of that one is though. But that's what they did for cubital tunnel. But same scenario, same concept behind it with Phelan's and with Phelan's sign and then Tinel's sign. So be sure that you understand those and look them up if you need to. Well, not if you need to. Look them up on Blackboard, the videos I posted. All right, rotator cuff tear. Diagnosis is based on exam. They will have pain. One of the signs and symptoms is pain, but if it goes past the elbow, it may not be rotator cuff. So rotator cuff injury occurs from overuse or irritation of the shoulder joint or traumatic injury. Diagnosis is based upon exam. The patient experiences pain with movement, especially when lifting their arm over their head. The severity of the injury is determined by X-ray or MRI. All right. Treatment includes NSAIDs, and the patient is advised to rest. Patients are unable to sleep often on the affected side, and the pain is much worse at night. So same as with carpal tunnel we discussed, the pain was worse at night. Same thing with rotator cuff tear, and they can't sleep on that side. So if it was my right shoulder rotator cuff, then I would not be able to sleep on my right side. If surgery is needed, the client needs to mobilize the shoulder for several days to weeks, and they need physical therapy. The client should have full recovery in 6 to 12 months. This is a long, arduous process. The physical therapist that I end up going to right now is specialized in hands or hand physical therapy, but I have been previously to physical therapy for other joint issues. And I don't think that I think every time I've been, there has been at least one person that's been in there rehabbing from a rotator cuff surgery. Very common. All right, ligament and meniscal injuries. So these occur as a result of a traumatic injury. Things like your ACL and your MCL is what you hear about the most, your anterior cruciate ligament and your medial cruciate ligament, and these are in your knee. They occur when the client is standing firmly and receives a blow or twist in a different direction while hyperextending the knee. The menisci can become injured, disrupting the stability of the leg when flexed or extended. So clients with meniscal injuries will often complain that their knee gave out or locked up, or they will tell you that they heard a popping sound. And thank goodness I have not had that happen. But I've seen a couple of kids on the soccer field go down with an ACL, and it seems like they immediately go down and are in excruciating pain right away. They know it. And you see that often if you watch football games and sometimes basketball games, where they plant and then turn, just twist a certain way, a different direction, hyperextend the knee. It's very painful. All right, treatment includes NSAIDs and ice for the first 48 hours. If the meniscus is torn, the surgeon will perform a meniscectomy to remove the damaged cartilage. Recovery time is 3 to 12 months, depending upon the severity of the injury. You have to gradually reintroduce the activity to prevent any further injury. These patients often, I see a lot of these people on the soccer field, and they are wearing large knee braces still, with the metal going up the side and trying to really help stabilize the knee for a significant amount of time. This is even after they've done this 8 to 12 months of rehab, and they're finally back out on the soccer field. They're still wearing these big braces for support. All right, fractures. A fracture is a break in the continuity of the bone. Blood seeps into the area of the break. A clot is formed, and over time, these cells form a callus, which stabilizes the bone. Full bone remodeling may take up to 12 months. So how is this information important to client education? One of the things that's important is that the bone is not really back to normal for 12 months. So they get a cast, you break your arm, you put on a cast, you're in the cast for 4 to 6 weeks. And we tend to think, oh, it's all good, we're out of the cast, we can be back to normal activities without any problem. But the reality is that bone is truly not fully healed. And that really takes a good 12 months. So they will often encourage and recommend, now whether patients comply or not is up to them, but they will often encourage and recommend splinting still for an extended period of time to prevent refracture. All right, so let's discuss the different types of fractures. We've got an avulsion fracture, comminuted, compound, compression, green stick, oblique, pathologic, spiral, transverse, and depressed. Again, I hope that you will pause the video, go to your book, look up these definitions before I tell them to you, because you will understand them and comprehend them much better if you do that. But I'm going to go ahead for these purposes and tell you what these definitions are. But these are things you're going to have to know. You need to understand the difference in these types of fractures. Fractures usually will occur from a direct blow or force, but sometimes just from strong muscle contractions like seizures. Sometimes bone infections with osteomyelitis can cause fractures, bone tumors, and decreased bone density. But let's go back to avulsion fracture. So an avulsion fracture, I think I just talked to you about that Monday. So hopefully you remember I talked about an avulsion fracture when I tore my the ligament or the tendon in my foot. I think I told you guys about that. So the fragment of the bone is pulled away by the ligament or tendon. So when that ligament or tendon is actually stressed and torn, it takes a piece of the bone with it. So that's an avulsion fracture. A comminuted fracture is where the bone is splintered into several pieces. All right, compound fracture is when the damage involves skin. So the bone breaks and pops through the skin. This happened not that long ago. It's probably a couple years ago. Seems like not that long ago. Basketball game. I think it might have been U of L. right there by the sidelines. The guy was just going down the sidelines and snap, came right through the skin. These people have a very high risk for infection, obviously. You can Google any of these and see some really gruesome videos. Let's see, what was that compound? So compression fractures, this is where the bone is compressed. So these are often things like vertebral fractures. You know, if someone jumps from a building or whatever, jumps from something, and that force of that compression causes damage. We've got a green stick fracture. This is a pediatric fracture where one side of the bone is broken and the other side of the bone is bent. Pediatric patients, their bones are much more pliable and not as brittle as adults. And so their bone can actually bend rather than actually break, and doesn't necessarily break all the way through. So that's what this green stick fracture is. An oblique fracture is where the fracture occurs at an angle across the bone. Pathologic fracture is a diseased bone. So this is a bone that has decreased bone density or osteoporosis or osteomyelitis. That's going to cause a pathologic fracture. A spiral fracture is a twisting fracture, so twisting around the shaft, and that's what you can actually see. And I'm pretty sure there's a good picture in your book about that, of the bone that breaks from a spiral fracture. And this is one of the fractures that especially if a child were to come in with a spiral fracture, tend to think of as an abuse fracture. Transverse fracture, this is straight across the bone. And a depressed fracture, and this is a downward fracture, like a skull fracture. If someone gets hit in the head and they fracture the bone, it's depressed down into the skull cavity. And the other one that I don't actually have listed on here, but I want you to kind of jot down, is a stress fracture. And a stress fracture is a crack in the bone from overuse. It's often not evident on x-ray for a few weeks. It's usually seen in lower extremities of athletes with high impact sports, so things like basketball, soccer, runners can often have stress fractures that go undocumented or undiagnosed for a couple of weeks even. All right, so complications from fractures. Compartment syndrome, I hope you remember we talked about that on Monday, what that was. But with compartment syndrome, we have tissue perfusion that is compromised related to swelling. We need to elevate the extremity, do neurovascular checks, apply ice. The signs and symptoms for compartment syndrome are severe pain that's unrelieved by medication. All right, thromboembolism is another complication of a fracture. This can lead to a pulmonary embolism, which results in anxiety and decreased saturation. And we give these patients low-dose heparin if we're concerned about thromboembolism. All right, then we've got a fat embolism. Fat embolism is most often seen after a long bone fracture, crushing injuries. So often after femur fractures, we'll take note to monitor specifically for fat embolism after a femur fracture, because it's one of the long bones. Provide early immobilization, respiratory support, such as turn, cough, and deep breathe, and monitor for respiratory distress. So obviously signs and symptoms of respiratory distress are increased respiration, cyanosis, grunting, confusion, retractions. But these symptoms or these issues that would make us lead to thinking, oh, we may have a fat embolism, are going to occur usually within the first 48 to 72 hours after the fracture. So we have a very specific time frame on when we might note these symptoms for a possible fat embolism complication. Delayed healing can lead to a non-union and or malunion. So a non-union obviously is when the bones are not going to come back together, and a malunion is when they come back together but they're not aligned correctly. A malunion, malalignment. Infection. All right, so the chances increase with the compound fracture. Obviously, application of skeletal traction or surgical procedures are going to increase our risk for infection. We need to use aseptic technique. Avascular necrosis. I think we talked about that on Monday a little bit, but hopefully you remember it's the death of the bone from insufficient blood supply, and how you would notice, or signs and symptoms of avascular necrosis, are going to be pain, unable to use the affected limb. Most commonly occurs in the femoral head. Okay. See table 62.1 for complication of the fractures on page 1077. So You guys got to know these things, understand them, make sure you understand the differences between them, the signs and symptoms, what you would look for, things like that. All right, signs and symptoms of a fracture. Pain. Obviously, pain is the most common symptom. Loss of function. The patient cannot use that extremity. A deformity. Obviously, if there is a gross deformity, an unusual position, you know something is broken. The picture I think I had at the very beginning of this little thing. Obviously, something is broken in here. Okay. False motion. So this is an unnatural movement or an unnatural motion. If something is moving not the way it should be, or then we've got to look into fractures. Crepitus. If y'all remember crepitus, it's that grating sound of the bone ends moving over each other. It can also be caused by air trapped in the soft tissue, and you hear this popping, clicking sound. Edema is obviously a very huge thing that occurs with a fracture because you've had trauma to that area, so our body's going to react and automatically cause swelling. Sometimes we can't do anything about the fracture or the issue until the swelling goes down enough to really see what's going on. Spasms, these are caused by muscles near the fracture contracting, and if a long bone is involved, so something like the femur, the spasms may actually cause shortening of the limb. All right. One or more x-ray views can determine if a fracture is present and the severity of the fracture. Some cases, CT or MRI may be necessary. Stress fractures won't be evident for a few weeks. So, I think I told you guys the story about my foot when I broke my foot the first time. I mean, my right foot, that's the one I broke first. With a crushing injury, and I went and had an x-ray, and they were like, oh, nothing's broken, and I'm like, really? I just can't even fathom that nothing is broken. I mean, this multiple sheets of pieces of sheetrock just fell on my leg and crushed my leg and broke the floorboard, and I was trapped under it. I'm sure something broke. But they did later discover, yes, I needed to go see a specialist. But even after all this went on, the therapy and everything kind of near the end, we went ahead and did a MRI on my foot, and you know what she came back with was there's several micro fractures in there, but there's nothing. They're so minute, and there's multiple micro fractures that they're growing back together, but there's always going to be issues. I mean, I have a lot of foot pain because of that, and it's gonna always be like that. Nothing they can fix. But it was much more evident on the MRI than it was on x-ray. All right, the goal of treatment is to reestablish functional continuity of the bone. Treatment discussed in Chapter 61, traction, reduction, internal and external fixation, and casting. Nursing management includes assessing for neurovascular and systemic complications, administering analgesics, provide comfort measures, assist with ADLs, prevent infection, promote physical mobility and skin integrity, and prevent constipation. Constipation comes from what? Talked about it on Monday. Hopefully you know or remember that constipation with these patients is increased due to their immobility as well as their pain medication. All right, fractured femur is the most often the result of a trauma. It's high risk for bleeding, very high risk for bleeding. The human body has 5 liters, 500 or 5,000 milliliters. You can lose up to 1,500 to 3,000 milliliters with a fractured femur. That is a significant portion of your blood supply. The client will have severe pain, swelling, and ecchymosis, most often treated with some form of traction. The client is confined to bed. The nurse implements measures to prevent complications of immobility and inactivity. We need to work on pen care. We've got to work on the diet, which we've already discussed. We have to take respiratory measures so they don't get pneumonia while they're bedridden, and work on constipation. All right, femur fracture. So here's a nice picture of a femur fracture up here. Fractured hip affects the proximal end of the femur. Hip fractures are often fractures of the femoral neck. Results from falls and affects older adults with osteoporosis primarily. I'm going to tell you a story real quick. My sister lives down in South Carolina. But obviously my parents are here, and her husband's mom lived here. And a couple years ago, they were up here getting some things packed up because her mother-in-law ended up moving down to South Carolina with her. And they were getting ready to pack things up and for the move. And she fell in the garage. Literally, they were like leaving the next day. She fell in the garage and fractured her femur. Oh my gosh, it was a big hoopla. Weeks. She ended up spending weeks up here, weeks in the hospital and rehab, and it was a big ordeal before they could finally even get her down to South Carolina. The client complains of severe pain with movement of the injured extremity. The injured extremity looks different. So hopefully you can kind of draw back on some of the things we've already talked about and fill in that blank. But if you can't, I'm going to tell you, the injured extremity is going to be shortened and externally rotated. So remember we talked about the muscle contractures, and because that bone is fractured now and it's going to contract, the muscles are going to contract up and make the leg appear shortened and externally rotated or abducted. Okay. A large amount of blood loss may accompany the fracture, leading to hypovolemic shock, so we have to monitor for that. Hip fractures are prone to non-union and avascular necrosis. We already talked about that the femoral head was one of the most significant places for avascular necrosis. Therefore, hemiarthroplasty is performed. Hemi, meaning half. So a hemiarthroplasty is where half of the hip joint is prosthetic. So the bone then heals around the metallic device, and then the bone will be united. All right, nursing management includes that of a post-op client confined to bed, which we've already discussed. See Chapter 61 for proper body alignment for a client with a hip replacement. Let me get all this back in order here. All right, proper alignment for hip replacement. I hope you pause this and fill this in on your own before I tell you what I've got. Sit the patient with the hip angle, what? We talked about that Monday. So greater than 90 degrees. Why do we need it to be greater than 90 degrees? Anything less than 90 degrees, we can dislocate or subluxate that new hip. Implement measures to prevent skin breakdown. Clean when soiled. Barrier creams. Turn every 2 hours with an abductor pillow. Remember, that was one of the other things we talked about on Monday, keeping a pillow between the legs for hip replacement so that the hip does not adduct. Wound infection. Monitor the wounds in the surgical site. Pneumonia. We've got to do deep breathing techniques. Constipation. Increased fiber and water intake. Urinary retention. This patient may have a Foley catheter in. Muscle atrophy and contracture. So we've got to do PT and get the patient up and walking as soon as possible. So complications from hip fractures can often lead to death for the elderly patient. More likely goes into complications. They get a hip fracture, and complications such as pneumonia and pulmonary embolism will often lead to death for the elderly client, unfortunately. All right, so here's another picture of my hip fracture there. All right, I'm going to start just let me see, how much am I going to do here? Looks like my page is out of order. Hold on. Well, what I don't want to do is get you all mixed up. Okay, I'm going to do just a little bit of 63 here. So 63, caring for clients with ortho and connective tissue disorders. First one is inflammatory disorders. Caring for clients with orthopedic and connective tissue disorders, inflammatory disorders. The first one is arthritis. All right. And I'm pretty sure everybody knows somebody that's got arthritis. And if you don't, you do now, because I have arthritis. So you all know me. All right. Arthritis is a general condition characterized by inflammation and degeneration of a joint. And then we've got rheumatic disorders. There are more than 100 different types. Most common rheumatic disorders is one of the most common orthopedic problems. So we can have rheumatoid arthritis is a systemic inflammatory disorder of the connective tissue and joints characterized by chronicity, remissions, and exacerbations. There's a high potential for disability for patients with rheumatoid arthritis. It is believed to be autoimmune. There's a strong genetic association with the HLA, the human leukocyte antigen. Most often affects women ages 20 to 40, but equalizes as adults age. So as adults age, it equalizes out in the men and women ratio. And RA affects small joints early in the disease and larger joints later in the disease. All right, see figure 63.1 for a photo there. We've got the inflammatory cycle. This is when the synovitis increases as congestion and edema develop in the synovial membrane and the joint capsule. We've got synovial tissue experiences reactive hyperplasia, which is an enlargement of the tissue. Redness and warmth occur due to vasodilation and increased blood supply. The pannus is a destructive vascular granulation tissue formation occurs. Pannus destroys the cartilage, the joint capsule, and bone forms between the joint margins, decreasing joint mobility, leading to ankylosis, which hopefully you remember is joint immobility. The disease does progress further, causing inflammation and structural changes. Assessment. The onset of symptoms is acute, and joint involvement is usually bilateral and symmetric. All right. Localized symptoms include joint pain, swelling and warmth, erythema, limited mobility, stiffness. As the disease progresses, clients often experience anorexia, weight loss, fatigue, and malaise. Other systemic features include vasculitis, which is an inflammation or destruction of the blood vessels, neuropathy, scleritis, inflammation of the sclera, pericarditis, splenomegaly, and Sjögren's, I don't know how to say that, syndrome, which is when you have dry mucous membranes. We have a decreased tolerance for stress and temperature changes. And rheumatoid nodules may appear. These are evident over the bony prominences and are non-tender and movable. Later stages include muscle wasting around the affected joints, thus accentuating the appearance of the swelling. So there's muscle wasting, but the joint still looks very enlarged because of the swelling. So is it the proximal or the distal finger joint that swells the most, showing the classic RA deformities? Hopefully you'll pause and take a minute to look in your book. But the answer is the proximal. Proximal finger joints swell the most, showing the classic RA deformities. All right, swan neck deformity, boutonniere deformity, and ulnar deviation. I'm going to run through these real quick, and I think I'll do this slide one more. Swan neck deformity. This is a hyperextension of the proximal interphalangeal joint. Let's go to the picture while we're talking. All right. Hyperextension of the proximal interphalangeal joint with the fixed flexion of the distal interphalangeal joint. Distal interphalangeal joint flexion, hyperextension of the proximal interphalangeal joint. So if anyone here is double jointed, which I don't know if you can see how this goes in. So this is your hyperextension in the proximal and your distal interphalangeal flexion. But it's constantly like this. Like I can make it do that and then I have to stretch it back out. But I can obviously make it undo that. All right, boutonniere deformity. It's this one up here, so it's kind of going to be the opposite. It's a persistent flexion of the proximal interphalangeal. Where's my little mouse? There we go. Persistent flexion of the proximal interphalangeal joint with a hyperextension of the distal interphalangeal joint. Right? And then we have your ulnar deviation, which is when the fingers actually deviate laterally toward the ulna. So the fingers actually just start deviating towards the ulna that way. All right, at this stage in the disease, clients have chronic pain that is worse when? Is it worse in the morning or at night? So for these patients, chronic pain is usually worse in the morning after resting all night. Symptoms may resolve suddenly. The client will be free from joint inflammation, redness, pain, and fever. However, symptoms will return. Inflammation will lead to more joint damage followed by another remission. So it's this cycle, constant cycle of remission, exacerbation, remission, exacerbation. Actually, let me just finish out RA since I'm recording anyway. So, diagnostic findings and medical surgical management. Diagnostic is X-ray, shows joint changes and the extent of the damage. We can do an arthrocentesis, which if you'll recall was an aspiration of the synovial fluid. With rheumatoid arthritis, the synovial fluid will usually be cloudy. Excuse me. Cloudy, milky, or dark yellow and contain inflammatory cells. Normal, it would be clear fluid. Arthroscopic exam may be done to visualize the extent, it's a typo, sorry, the extent of joint damage, and can also obtain a sample of synovial fluid with an arthroscopic exam. Medical surgical management. There is no cure for RA. That's significant. No cure. The goal is to decrease joint damage and inflammation before bony ankylosis occurs, relieve discomfort, prevent and correct deformities, and to maintain or restore function to the affected structures. NSAIDs and steroids are used to relieve pain and inflammation. Treatment goals include decreasing joint inflammation before bony ankylosis occurs. We will also use disease-modifying anti-rheumatic drugs, so DMARDs. I'm sure you guys went over that in Pharm. These reduce the amount of joint damage and slow damage to the other tissues. These are called gold preparations, and there is a list, let's see, on page 1087 in your book, drug therapy table on 63.1. And the drugs that I want you to kind of pay attention to are Celebrex, Imuron, methotrexate, Humira, which includes Humira, Enbrel, and Remicade, and Plaquenil. All right, back up here on DMARDs. Gold preparation, methotrexate. One of the things, some of the side effects though with methotrexate is nausea and vomiting, a decreased appetite, hair loss, unusual bleeding and bruising. Immunosuppressants calm the immune system. They also suppress the immune system, therefore increasing the patient's risk for infection. And Imuron falls into that category. So your DMARDs, gold preparation, methotrexate falls in that. Imuron falls in your immunosuppressant therapy. Your TNF alpha inhibitors, they reduce pain and inflammation by blocking cytokines. And that is, these also suppress the immune system. They are often given with methotrexate, but these medications are things like Humira and Enbrel. These are TNF alpha inhibitors. Then you've got Prosorba therapy, is when blood is taken from one arm, run through an apheresis machine to separate the plasma from the red blood cells. Plasma then passes through the Prosorba column where some of the RA antibodies are removed and then placed back into the client in the other arm. All right, the client may have arthroplasty, reconstruction of the joint, or synoviectomy to remove the lining of the joint. All right, so what are some goals of the nurse caring for the client with RA? Education is always a huge thing. Medications, explaining the medications, home care, diet. So hopefully you'll take a few minutes to pause and kind of look this up for yourself first. But for under education, what I have is educating regarding their general health, reducing stress, decreasing the inflammatory process, and preserving joint mobility. For medications, aspirin. But you've got to be sure that you educate about not taking aspirin with ulcers or other bleeding disorders. NSAIDs, these will upset the stomach. Steroids, never stop abruptly. Increases the risk for illness because they suppress the immune system. Right? Instruct them to take the medications even when they feel better, These medications are as maintenance therapy. That's a huge thing to educate patients on. Home care, who's going to help them with their ADLs? Be sure they're eating a well-balanced diet to prevent malnutrition. There has actually been no conclusive evidence shown that nutrition therapy can prevent attacks or cure RA. But if you look it up, there are multiple dietary management that people feel very strongly have helped relieve significantly their RA symptoms. All right, in the acute phase with rheumatoid arthritis, they still need to be sure that they're moving their joints. All right, I'm going to stop there. So I'm stopping at degenerative joint disease. And we'll talk a little bit more about that for the next test. Okay. There's going to be a bit of an overlap, and there's no other way for me to do that, and I think I do that every semester. There's going to be an overlap between that because I need to, on both tests, there's going to be a bit of questioning about these inflammatory disorders because they all kind of flow together, but I've got to keep going to get it all done. So I'll probably have a few questions on like the rheumatoid arthritis on this exam, and just so that you know, in the next exam, they're still going to have some other stuff about rheumatoid arthritis, and then moving on into degenerative joint disease and the other issues that we're going to discuss for the, what would that be, the fourth exam? 4? I think that's right. Okay, so next week I'll finish up all the rest of this, and the week after that we'll do all of Peds Ortho, and then we're on to 205. Be sure you let me know if you have any questions.